The first topic will be presented by Sigmund Silber from München, to stop or not to stop antiaggregation or anticoagulation before a procedure. Sigmund, please.
Well, dear Maxime, dear Arno, ladies and gentlemen, thank you very much for inviting me to give this presentation. And as you know, the topic is nightmares in clinical practice, and I was asked to present a nightmare, so I will present you a real nightmare. To stop or not to stop antiaggregation, anticoagulation, this will be a part of the procedure, but the procedure, of course, since I'm a coronary guy, the procedure will be a PCI. So I will present you a nightmare presentation, and then what's also very important is the questions. We can discuss this further later on. Did the physicians follow the ESC guidelines? Could this nightmare have been avoided? And last but not least, I will give you some conclusion and practical recommendations. So let's start with the case presentation. It's a 77-year-old patient with a heavy smoker, high blood pressure, moderate renal insufficiency, and he was actually referred to our practice in June 13th this year. So it's an actual case, not an old case, but it's a new case. He was referred to our practice for myocardial perfusion scintigraphy. Why? Because his physician said something is wrong. The patient had got 5 coronary stents, he had bypass surgery in April, and he still has limiting angina. So what's wrong with this guy? Well, when I saw him, he was on triple therapy. Interestingly, no proton pump inhibitor despite triple therapy, and the other drugs you see here. Physical findings, echo was more or less normal, nothing special. Here's his resting EKG with some resting abnormalities, as you can see here, but still good R-wave progression here. So he was referred for scintigraphy. I hope you can see it here, despite the daylight, I guess so. So what you see here is during stress an anterior defect and at rest some normalization. If you look closer in the vertical long axis, I think you can see this here very nicely. It's a large anterior wall defect at stress and normalization during exercise. So what happened to this poor guy? With 5 stents and after bypass surgery, this is not the way it should be after 2 revascularization procedures. So what happened? Now we go back to March this year. He had coronary angiography in another hospital in Munich, and for the first time, 3-vessel disease was diagnosed with severe complex proximal circumflex lesion with a complex bifurcation, LAD diagonal branch lesion, and some lesion here in the right coronary. So this patient who has stable angina was given on the cath table the choice between PCI and open heart surgery. And if you do this, there was no heart team discussion, no heart surgery in-house. So of course the patient chose PCI, and he received 2 drug-eluting stents in the RCA, which had a pretty good results. So about 6 weeks later, he underwent planned PCI of the LAD diagonal branch here. He had aspirin, 250 milligram intravenously, despite he was already on oral anti-aggregation, plus additional heparin, 7,500 units. And he got 2 long stents, you see here, distal LAD, 30 millimeter stent, proximal LAD. So he got 6 centimeter stent with a nice result, but as you can see here, the diagonal end branch was lost, occluded. So the operators choose to use high pressure, 24 atmospheres, non-compliant balloon, and then suddenly perforation occurred with a perforation. I hope you can see that here, and a perforation up there. So the patient was in real trouble. So of course, the patient got a covered stent, a graft stent here, as you can see here, which is the treatment of choice for perforations, but it didn't help. So despite the patient got the graft stent on the right spot, he still had ongoing perforation, ongoing cardiac tamponade, and he had several CPRs despite cardiopacentesis, and then he was immediately transferred to the surgical department of our institution. Intraoperatively, very interesting, he showed active bleeding from the diagonal branch. So the ongoing perforation was the diagonal branch, so there was no chance for the graft stent to fix this problem. Well, bleeding was closed by the surgeon, of course, and since the patient was in severe cardiogenic shock, they did just the most important thing, which was the single venous graft on LAD. Patient recovered well during rehabilitation. He developed atrial flutter, and this is why he got additional rivaroxaban. So what happened there? What would you suggest to this patient? Because he still has angina after all this trouble. So of course I suggested another coronary angiography, and before that procedure, aspirin and clopidogrel was not stopped, because this is one of the topics of our session. Should it be stopped, yes or no? The answer is no. Why should you stop aspirin before coronary angiography with a planned PCI? Rivaroxaban, however, was stopped about 24 hours before procedure. So this is what we found. Lesion here, lesion there in the LAD, huge instant restenosis in the LAD. So this explains actually the ischemia in the anterior wall. But the complex proximal circumflex was still not treated, neither with stents nor with surgery. And last but not least, poor luck patient, the venous graft to the LAD was occluded. The only good news was the right coronary was still in good shape. So what do you do in this conservative? You do conservative treatment, or you go for a third PCI or second open heart surgery within 5 months. So of course the patient said, do whatever you think is right, but no more PCI. This was such a terrible experience. So he chose to go for a second cardiac surgery. So here come the questions now. Did the physicians follow the ESC guidelines? And if not, why? And if yes, that's good. So we have 4 questions regarding the heart team approach. Well, if you look at the Congress back, you will see that the heart team actually is the spotlight of the ESC Congress of this year. This is the emphasis of this Congress, is the positive advantages of a heart team. And actually the heart team is nothing new. We have presented the concept of the heart team about 6 years ago at the 2010 ESC guidelines for myocardial revascularization, and so this should really be done. In the last guidelines, we have suggested for multi-vessel, and this is what the patient had, multi-vessel stable coronary disease, that multidisciplinary decision-making is required. And this was not the case in this case. And why is this? Because the patient with stable angina should be given enough time to be allowed for informed decision-making. So the answer is no. Regarding the heart team, the ESC guidelines were not followed. What about the use of the graft stent? Was this according to the guidelines? Well, in the last guidelines from 2014, it says that fully covered stent can be life-saving in the rare event of coronary perforation. Yes, actually this was nothing new, because in the first PCI guidelines, already 2005, we already have recommended PTFE covered stents, so-called graft stent, even at the level 1C on the basis of expert consensus. Well, what is a rare event? I was asked by the chairman to bring some up-to-date literature, and the latest literature I found was this one, just published online from Great Britain, British Society, over 527 cases of PCI. And these are the occurrences of coronary perforation, which is pretty much stable, 0.3% throughout all these years. And the mortality of coronary perforation is 8 times higher than of no perforation, 8% in-hospital mortality with perforation. So perforation is a very rare but very severe condition. So yes, the physicians followed the guidelines regarding this point. What about not stopping anticoagulation with protamine? The patient got heparin, he perforated, he had severe cardiac tamponade. So actually in the guidelines 2005, we already have recommended the administration of protamine, but in this case, the patient, for some reason, I don't know, did not receive protamine, so this was not followed by the guidelines. And last but not least, the other thing was, patient was on triple therapy, he was on rivaroxaban. This was stopped 24 hours before procedure. Was this within the guidelines? And I'm sure you know this table. This was published last year, but also this year in an update. And as you can see here, on rivaroxaban, his GFR was 53 milliliters per minute, so it was stopped for 24 hours. So this was within the guidelines. And I really highly recommend this table if you want to know to stop anticoagulation, especially NOACs, before any procedure. So yes, this was within the guidelines. So what is the future? The future, we will have antidotes. We will already have the antidote for dabigatran, which is commercially available. So if you have a perforation with dabigatran, you give Prexbind. The others, the 10A factor inhibitors, still are on the way. The Annexat alpha is not yet approved, but we hope it will be approved in the near future. So in the future, I think coronary perforation with NOACs will be easier to manage. So last but not least, the conclusion. In patients with stable but with complex three-vessel disease, the decision of PCI versus bypass surgery should be discussed within the heart team, but you have to give the patient enough time to understand this important issue. Don't rush into complex cases in stable patients. There's no need to rush. Coronary perforation is a very rare 0.3%, but potentially life-threatening complication with an in-hospital mortality of 8%. Emergency surgery is required in about 3% of these patients, like in our patient here. Totally covered stent, so-called graft stent, for sealing the perforation must be available in various sizes in all PCI labs. In case of a coronary perforation, immediate reversal of anticoagulation may be helpful. This is possible with protamine when you use unfractionated heparin. To enable the use of unfractionated heparin for PCI in patients with oral long-term anticoagulation, the discontinuation of vitamin K antagonists in stable patients requires bridging. The advantage of NOACs is that bridging is not necessary. So bridging is history. NOACs should be stopped according to the type of drug, renal function, and risk of bleeding. You remember this table. You always have to keep this table in mind. For dabigatran, an antidote is already available. So stopping dabigatran before PCI should not be necessary. That's my personal opinion, at least. Hopefully soon we will also have the antidote for 10A inhibitors will also be available. Making PCI in patients on long-term anticoagulation with a NOAC easier, especially in patients with ACS where you cannot wait, you just have to go into the case. So we would be very happy to have antidotes for all the NOACs. Thank you.
Thank you very much, Sigmund, for this very interesting case. The case is open to discussion. Is there any question from the audience? Yes?
Thank you for this case. According to protamine sulfate using in this case or other cases, I think you have to avoid protamine sulfate in cases with multiple stents, especially in the main artery, because it may cause acute thrombosis and maybe inducing death maybe in some cases. So to me, it is you have to avoid protamine sulfate unless there is bleeding. There is no other choice to stop bleeding. I don't know what is.
Well, I completely agree with you. That's a choice between, in German we say, between pest and cholera. So you choose between two terrible diseases. And but this patient already had pericardiocentesis. He had 1,200 milliliters of blood already drawn, and he was almost dying. I mean, of course, it's easy to say you should have used protamine. It's easy to say, no, I didn't use protamine. The patient survived, luckily. But you're right. I personally, in that situation, probably would have used protamine. But it's always easier to say, I would have done, I would have that. But your point is well taken.
Please, if you can present you before the question.
Yes, yeah. Tamer Mustafa, intervention cardiologist, Egypt. I want to ask about the use of rivaroxaban as a part of treatment, essential treatment for this patient. Is this anti-ischemic part, or is there another indication?
No. This was not the anti-ischemic low dose like from the Atlas trial. He had received rivaroxaban during rehabilitation where he developed atrial flutter. So this was for prevention of stroke.
The start before the development of atrial flutter, according to the course I see.
He did not have rivaroxaban before that. He got rivaroxaban after heart surgery, after flutter.
After flutter, yeah. Thank you.
But we stopped it after the diagnostic cath because he had no atrial flutter in the meantime. And you're right, the indication is kind of to be debated. So we stopped rivaroxaban.
And practically now we use the rivaroxaban in ACS in Europe or not?
Oh, difficult question. Yes, some people do it. I personally, I'm not a big fan of the low-dose rivaroxaban. We need more data. You know, the problem with rivaroxaban in acute coronary syndrome is that the Atlas trial used clopidogrel as an anti-aggregational drug. And we did so many efforts to switch from clopidogrel to either prasugrel or ticagrelor. And even the guidelines say use clopidogrel only if prasugrel or ticagrelor are contraindicated. So after we switching to prasugrel and ticagrelor, we don't have any data on low-dose rivaroxaban with prasugrel or ticagrelor. So I personally don't use it.
Okay, thank you.
There's another question there. Yeah.
I'm Dr. Güneri from Turkey. My question is, what is your, what will you do with this patient in the future? The grafted stent is restenosed, and
yes.
There's a severe proximal circumflex lesion. What is your opinion on that? Another surgery? Probably.
Well, we discussed this very thoroughly with the patient, and he said, I do whatever you say, but no PCI anymore. I mean, so he decided to go for surgery. Unfortunately, he's not yet operated. He had hemoglobin of 6 recently before surgery, and the reason were 2 major bleeding ulcers in the stomach. So he is so stressed now that even the surgeons will not touch him. So he gets infusion treatment of the ulcers, and then hopefully everything will be fixed. It will be difficult for the LAD because the LAD is stented more than 2/3, so the surgeons don't like it, as you know. But I'm sure that the complex lesion in the circumflex and the marginal branch will be bypassed.
Okay, I have one question about the heart team, right? Because they didn't follow the guideline there, and I was surprised that the patient had to decide, I think, on the table whether or not you go for a PCI or a CABG later. So don't you think, well, how would you do that in your hospital? I mean, would you have kind of an official leaflet telling, you know, this is what you should do, this is the time you should leave the patient to think about it? Are nurses involved?
Well, we are lucky in our hospital. We have cardiac surgery in our division. So what I personally do is I just stop the diagnostic cath. I mean, if you know it's a complex case, the patient is stable. We do not talk about acute coronary syndrome. Then we stop diagnostic procedure. We call the surgeons. We discuss it first with the surgeon. And now what's very important, the surgeon and the cardiologist have to go together to the patient, but they have to make one opinion. So either the surgeon said, yes, I agree with stenting, or the cardiologist said, I suggest surgery. But the patient should not get 2 opinions. Sometimes in the heart team, patients get different opinions. This brings up to the question, what about hospitals not having cardiac surgery? The surgeon cannot come, although there's no rush. So in hospitals without surgery on site, I think they need written consent, at least with the surgeon, that in these cases you can go on with PCI. I agree as a surgeon, but in that cases, in stable angina, I just emphasize again, it's better if we meet this afternoon.
Thank you very much. We go to the next speaker.